Good morning, Carolyn.
And good morning, Dr. Rosensweet. It is wonderful to see you yet again. I'm hoping you're well.
I am.
Excellent. I am too. And I'm going to welcome everybody who's going to come in. And I am going to go ahead and start off with the questions because we have many. So here we go. Number one. Dr. Rosensweet touched upon his feeling about testosterone injections a few times, which many of us do use. We know that his feelings are strong enough against them, but could he please elaborate? I don't want to harm my body. Thank you.
It's all a matter of degrees. And one thing we have worked diligently for is creating standard of care. And that means what is the optimal, most excellent, safest, most effective care possible for a woman in menopause. And for me, would be replicate what the body does, which is number one, a daily output of testosterone. And the safest way to administer testosterone is topically. When you inject something into your body, it behaves in a special way. You inject it, and the levels go up really high, and then they gradually come down. And in the world of hormones, we do not love this peaking phenomena, this abrupt peak. Whereas when you apply something to your skin, it's a gradual uptake. So you don't get that intense peak. Outside of that, I mean, I haven't met a tremendous number of people that love injecting themselves. And, people get used to it. So I don't want to, if injectable testosterone was the only thing available to women, and it would be that or no testosterone, I'd say go for it. Absolutely, because testosterone is so critical.
Right.
I've seen different injection regimens that last you inject once a week, you inject twice a week, or even daily. I am not a fan at all of once a week or injection of anything. It doesn't replicate what the ovaries did. The ovaries did a daily nice output. So what's the optimal for testosterone? Well, it certainly isn't oral, because that can injure the liver. So that's totally out and you can't even get it. It's topical. And the way that you can get topical testosterone is through your friendly compounding bioidentical hormone pharmacy. They do a great job. And of course, my absolute favorite way is testosterone in a certified organic oils base.
Shake it up.
It's not there's no solvents in there. So like Carolyn was demonstrating, you do have to rotate the bottle. You do have to, but that's really easy. And we have that for men as well. So this is my bottle. Testosterone.
Maybe we can share.
Yeah. The injectables, they do this peak thing. You inject that within an instant, within microseconds, you've got a very high level of testosterone, and then you gradually decline. I don't like peaks of anything.
Right. Some people tend to like those peaks.
But my orientation is medically, what's the safest for the body? What copies nature the most? Absolutely.
So would that also include estrogen injections, or I mean,
a long time since I've run across someone who's doing any estrogen injections.
Okay.
I wouldn't even know how to answer it. I don't know that I've run into anyone doing that in decades.
Got it. Okay. Well, thank you. That peak spike thing, you're talking about copying nature in the way that the ovaries did, correct? Naturally.
And slow. And when you apply something to the skin or a mucous membrane, it doesn't do this high peak. No, it gradually enters the skin, gets into the bloodstream. It's much softer.
Cool. Okay. Well, thank you very, very much for that. Quickly, because we didn't get to this question in our last interview. We didn't get to, yeah. Anyway, the woman is asking, should we take a break from our hormones on the 7th day of each week?
Well, it's the question is around, should a woman take a break at any time from taking her hormones? And in the menopause method, we have a break designed, but we don't do it once a week. I've never quite gotten once a week. I mean, what nature does in a young woman is once a month, the hormone levels drop really low. But let me review the purpose of stopping hormones. Let's say that you're applying a certain dose of Biest, for example, every single day. And you're applying the exact right amount, not 2 molecules more. You wouldn't really have to stop. There would be no need to stop. Let's say you were applying 2 molecules less than what your body wanted. I mean, it's a ridiculous way to put it. You wouldn't want to stop. But let's say that you're applying 3,000 molecules more. I don't know, 3,000. You're applying a little extra. Well, we don't, because these hormones are fat soluble and you were applying a little extra and you didn't feel that you were because you didn't get so far as to get breast tenderness or something, but you were still applying a little more each day than your body actually needed, then what you would do over a time, because these hormones are fat soluble, is you would accumulate Biest, estrogen, in the fat cells of your body, and you gradually build up extra hormone, just like you would vitamin A or vitamin D, which are fat soluble. We don't want to build up the strategic adipose reserve, the fat cells. We don't want them to overflow with estrogen because you were taking a little bit too much dose every day. And so we do recommend that once a month, a woman stop taking her hormones. In the initial phases of helping a woman determine the optimal dose, we don't have her stop her hormones at all. But once the woman has alleviated her symptoms and feels pretty content, that's usually anywhere from 2 to 5 months in our program. And then we test her with the 24-hour urine hormone test to confirm that her levels are in the optimal zone, and we know what that zone is. We've defined that zone really through the medical literature, not too little and not too much. That's when we'll ask a woman to once a month stop her hormones. And here's the ritual we use. We say, let's say, for example, on the 1st of each month, because it's easy to remember, or on the full moon, whatever's easiest to remember. On the 1st of each month, don't take your hormones. And don't resume them until you get a symptom of estrogen insufficiency, for example. So you get your first warm rush. And let me give you an example how that goes. I omitted my hormones on the 1st of the month, and I felt fine. I omitted my hormones the next day too, on the 2nd of the month, and I still felt fine. I omitted my hormones on the 3rd day, and by midday I got a hot flash. What does that tell us? That by midday on the 3rd day, her hormone levels dropped much lower than what her body wanted. And she got a hot flash. So what we instruct that woman to do is, instead of omitting hormones for 3 days each month, because you got a hot flash on the 3rd day, thenceforth, we have you omit 2 days each month. We don't want you to drop your hormone levels so low that you get symptoms. That's not healthy for you, and it's a little tricky to recover from that, actually.
Right.
But we do, as a safety valve, prevent you from long-term accumulation by stopping your hormones once a month, and in the case of the example, for 2 days. That will, if you think that one through, that's going to help prevent gradual hormone accumulation if there was an excessive dose being given every day that was undetectable by getting symptoms of overdose. It's very subtle. Those are the women. That's how we do it in the menopause method. Now, sometimes we don't have women stop. Sometimes the 24-hour urine hormone test will reveal that the woman is satisfied clinically, but she's hovering at the very low end on testing. That's one case we say, don't stop. You're obviously not taking too many hormones. And there's another case in which we'll say, don't stop. And when it's a woman says, if I stop for one dose, if I forget my evening biased or my morning biased, I'm going to get a hot flash. What do we learn about her? She's hovering on the very low end of what's optimal. If this is the low end and this is the high end, she's not floating on the robust end of dosages. She's floating right there at the edge of the low end. That happens occasionally where women are satisfied on the low end. They test out to show they've got enough estrogen to protect their brain and their bones. I'm sorry, to protect their bones and their vagina. Brain's a whole other story. And so they've got enough, but we don't want them to omit because we don't want them to get a hot flash. That's stressful. One of our strategies is don't get hot flashes anymore if we can possibly dial you in that carefully.
Thank you for studying that out. Absolutely.
That's why we stop once a month, once a week. I don't get it. Where's the strategy there? I mean, it doesn't copy nature. It's, you want to be careful. You want to stop enough so that you can determine how long should you stop. We only want you to do that once a month.
Oh, thank you so much. And it goes back to something you say that I love, and that is that we don't know what we don't know until we're told and we know, you know?
I saw a question flash up that I'd like to answer.
Please.
It's from Tanya, and she says, do you recommend stopping HRT before the first 24-hour urine hormone test? This is I want all of us to think this one through. One of the one of the most terrific advantages to doing a 24-hour urine hormone test is we get a measure of the hormones while you're taking them.
Yes.
We don't want to know what your hormone levels are when you're not taking them. That's of no value whatsoever. We only want to know what your hormone levels are while you're taking them. And we go further with our instruction. We say, we want you to collect your urine for 24 hours after you've been religious, taking your dosages just as prescribed, solid for 1 week, and you're not missing any. And then, of course, you would collect your urine during a standard dosage day. So, for example, you'd be applying your bias twice a day. Your progesterone at night, your testosterone and DHEA usually in the morning. We don't want you to drop a beat. If we collect your urine on a very day that you're treating yourself with your hormones, we get a wonderful, beautiful, amazing readout of how these are in your body. So the last thing in the world we want you to do is stop your hormones. We want you to take your hormones like a religion right on through the collection period.
Excellent answer.
We want you to record, by the way, exactly what your dosages were and where you applied them on the day that you were collecting your urine. Because that gives us just a beautiful picture of what's getting in your body. And we know how much should go into your body. And we know what too much and too little is. So we're trying to assess your treatment. And so we have you collect your urine.
Thank you for that answer. That's one that comes up a lot. And that's very much appreciated. I'm seeing the questions. Get to them. We'll reply to you, promise. Number 2, I am 44 with only one ovary due to a hysterectomy due to severe endometriosis. And I think I've been in menopause for 1 year. I'm pretty sure I have been. Am I a candidate for hormone replacement therapy? Says the questioner.
It's a great question. And the answer is yes, and yes, and oh, by the way, yes.
Was that a yes?
That was a yes.
Got it.
If when you say you believe you've been in menopause for a year, I'm assuming you had no period, because one ovary still produces hormones and your body should adjust. And if you haven't had a period for a year and you still got one ovary, you're in menopause. Your hormone levels are low. I would suspect it's a high likelihood, not a certainty, that you have symptoms of insufficient hormones as well. And you can download a copy of our book and you'd learn what symptoms of insufficient hormones are. Now, I think your concern would be, if you had endometriosis, was this going to stir up the endometriosis?
Yes.
And this is a reasonable question. But the answer is unlikely, because you're not going to be dealing with the dosages of estrogen that was sufficient to produce an endometrial lining. I mean, the dosages we recommend in the menopause method is don't restore your period. Don't take so much estrogen that you're going to get an endometrial lining and you're going to have a period. Don't do it. And in fact, if this is the range of estrogen that a young woman has, and she needs that much, and this is the low end. Some women don't need as much as others do. This is the range that women will test out as who are young and healthy and having a regular period. This is the range of estrogen, for example. Our recommended dosages for menopause are below that range. We don't want you to bleed. That's a whole story. And we know that there's other systems that recommend that. And we say almost never for that, because the same dosages that will restore a period do what a young woman does, is put you at risk for breast glandular cell proliferation. We don't want that in a midlife woman. We don't want cell division and mitosis and vulnerability there. And we don't want increase in breast density. We don't want that at all. There is a rare exception, but we don't want hormone levels so robust that you are going to bleed and have a period, because that's the level at which your breast glandular cells, which they do every single month when you're a young woman, they prepare for lactation, possible implantation, fertilization, lactation. Every month you get extra breast glandular cells. You can feel that. Most women can feel their breasts get more full once a month. And then if you don't get pregnant, they get less full, and you go through that. Well, that fullness is partially a result of additional breast glandular cells. We don't want that in menopause. So the dosages are less in menopause. And please ask me the original question again, Carolyn.
She's 44, one ovary, hysterectomy, endometriosis. Yeah.
So because we're not replenishing dosages that are sufficient to form an endometrial lining that would bleed, plus we're giving you a really rich amount of progesterone. We want enough progesterone in your body so that it would suppress any desire of or ability of your uterus to form an endometrial lining, and thus endometrial tissue anywhere in your body. We don't want to activate that stuff. And we're dealing with lesser dosages. I assert that 95% of the women who've had endometriosis are going to do just fine on the dosages and hormonal balance with rich, robust progesterone that you would receive in treatment for menopause. Now, these are always, I mean, I think one of the things that this points out to me is the individual nature of one woman to the next.
Right.
So ideally, your job would be the same job as every woman who's in man, every man who's in andropause, every woman who's in menopause. You have one job, and that is to go shopping and find and connect up with someone who's specializing in treating women in menopause with bioidentical hormones and loves it and has received good education in it and has experience in it. They'll know how medically to monitor your situation, to individualize it for you. And I don't want to make it sound like a big deal, but I definitely recommend, since my recommendation is, and not just me, that no way, of the experts that I'm aligned with in the field of menopause, we all recommend that you get on hormones as early as you can, and you get on the optimal dosages, and you take them for the rest of your life on Earth. Here's my testosterone. I don't plan to miss a day the whole rest of my life on Earth.
Gotta say, I'm right with you there.
There's no reason to. So at any rate, someone should be able to dial in your hormone replenishment in a way that does not activate endometriosis, does not form progesterone, that it would suppress any endometrial tissue to form anyway.
Wonderful. Thank you, Dr. Rosensweet. My next question comes up stating, from our last interview, which is an unforgettable interview. That was a lot of fun. I overdosed on estrogen too, she says. I had to stop due to chest pains. My blood results revealed that I went from 56.6 all the way up to 532.0. So I was correct in my thinking that I was overdosed on estrogen. What I did is I increased my progesterone, which helped, but then I started bleeding. I did help my migraines, but now they're back. So should I increase my progesterone to stop this mid-cycle bleeding? I'm confused. Can you help?
Yes, I think. Help is always you don't want to overpromise and not deliver on help.
True.
It sounds like you're attempting to manage your own treatment program there. And you know what? I hate to admit it, but some women can get really expert and really...
you hate to admit it. Sorry for laughing.
Because I don't think it's the safest way to proceed with these most powerful biochemicals that your body produces.
Yes, I agree.
And very few people understand or know the optimal zone. Very few people understand why you don't want to give too much and why you don't want to give too little. Very few people could even begin to identify what is too little or too much. And to repeat something that I have brought out on our Facebook Live is a woman can feel after she started taking hormones that she's got it. I got it. Fantastic. My symptoms are gone. I feel so much better. We did a study on this of my patients, and 25% of the women who said, I got it. I found my right doses. 25% of them were on dosages of estrogen higher than what is acceptable and put them at risk for breast glandular cell proliferation. And 50% of them were on dosages insufficient to protect their bones and their vagina. That means nothing else is getting protected. Now, I don't want to scare you. This isn't an illness, and hormones don't cause cancer. So being on an overdose, don't get overly concerned. Just get it right. And blood testing is tricky because it depends when you took your last dose, what your blood levels are going to be. Did you take it 2 hours ago, 3 hours ago? Are you testing at a time when you're actually at your peak blood levels or trough, the lowest they ever get? When you're being tested, are you doing the same kind of interval testing from when you applied your last dose to when you're drawing that blood? This is a real issue, but I'm not challenging you at all that you were on an overdose. And, 90% of the women are not going to tolerate overdoses. They're going to feel it. Not 100%, but I don't know. I'm making a wild guess at 90%. But if you get too much estrogen, usually a woman gets breast tenderness, nipple tenderness, breast fullness, water retention, irritability, all kinds of estrogen excess symptoms that you will find in our book, spelled out in a couple of different locations. Too much estrogen. Then you get too much progesterone, you get too much testosterone. That's all possible. And the vast majority of women are going to feel it. They're not going to feel good. The only acceptable outcome in treating a woman with hormones is that she feels good and she doesn't get symptoms of too little or symptoms of too much. And that's achievable because we're replenishing the molecules that your body were used to anyway. Now, when you're playing with high estrogen doses, you named the risk, questioner, that you're going to form an endometrial lining and you're going to menstruate. No big deal. You're trying to figure it out. Being on an overdose of estrogen. Estrogen does not cause cancer.
Thank you.
So there's no consequence other than lack of feeling great. And maybe some breast pain and some swelling and stuff. And you don't want to counteract an overdose of estrogen that it's enough to give you bleed with high doses of progesterone. Now your thinking is pretty good. You know that progesterone, this questioner obviously knows that progesterone balances estrogen and that you need adequate progesterone to prevent overemphasis of estrogen effects. You need an adequate dose of progesterone to prevent a thickened or bleeding endometrial lining to the uterus. You need adequate progesterone to do that. So the questioner is getting the right idea here. But if you move yourself into estrogen overdose enough to bleed, you don't want to just bring in raucous, robust doses of progesterone to counter that. You want to get your estrogen within the goalposts of what's the optimal amount. Well, one of the things that we've done that I have yet to see anywhere in anywhere, and where people are treating and testing with hormones in menopause, is I went into the medical literature many years ago, and I was able to discover wonderful science articles on what constitutes too much estrogen and what constitutes too little estrogen. And we have that on the 24-hour urine hormone test with the lab we use. We have that clearly illustrated, too much and too little. And then progesterone, one can make a case for doing a rich amount of progesterone because it's good for you. It's good for your bones. It's good for your mood. It's good for your mind. And it's good for that uterus so that you don't form an endometrial lining, that you're going to menstruate. And there's different ways to monitor progesterone. And one of them is, for example, a transvaginal ultrasound. It's relatively not harshly invasive. They do stick a tube, but it's an ultrasound tube in your vagina because that's where you can get the best look of the endometrium.
Yeah.
The lining of the uterus. So we want enough progesterone that even if a woman's not bleeding, she's still not forming too thick of an endometrial lining. So we'll do that from time to time, that transvaginal ultrasound. It's a wonderful tool. Your gynecologist does them day in and day out.
They are experts.
So I'm wandering around there a little bit, but the best thing I could imagine for the questioner is to clinically determine by symptom alleviation what a good dose of estrogen is, biased, hopefully, topically, and what a good dose of progesterone is clinically. And we define, we describe in great detail in our book how you clinically determine. What does that mean? You go into menopause, you have symptoms of insufficiency, you start a dosage protocol, you keep increasing the application of estrogen and progesterone and testosterone and DHEA until your symptoms go away. And you could keep increasing to where you gave yourself too much, in which case most women would get symptoms of overdose. So if you get symptoms of overdose, you back down. And that's how you determine in your body, with your symptoms, clinically, if you're in the range of estrogen, progesterone, testosterone, and DHEA. However, it ain't enough. And I know I'm repeating myself because of the study we did on 54 of my patients, all of whom said, hey, I've landed, this is good. Yeah, only 25% of them were in the optimal zone of estrogen, for example. 25% had too much and were putting themselves at risk for breast glandular cell proliferation. I'm not saying cancer. I'm saying breast glandular cell proliferation, but that can lead to increased breast density, and that's no picnic, and it's not healthy. And 50% of them, even though they felt good, did not have sufficient estrogen to protect their vagina and bones over the long haul. And that really, really matters.
Oh, yes, and how.
So, have I said too much or enough?
You know my feeling on that.
And here's a questioner asking us, how do you know if you have breast glandular?
I was just going to ask that. You beat me to
it. Thank you. Well, in many women, it's fairly obvious. Your breasts start getting fuller. And if you go so far as to breast tenderness or nipple tenderness, that's a clear sign that you're on too much.
Got it.
What made the breasts feel fuller? What led to increased fullness of the breasts? Part of it relates to fluid, but part of it relates to you get extra cells of breast glandular cells. It happens every single month, once a month in a young woman. It's so astounding. I mean, I can't even get my brain around it. And I was introduced to this 55 years ago.
Yeah, it's amazing.
I still can't get my brain around how amazing the female menstrual cycle is. Because once a month, human females are preparing for pregnancy. Well,
we're creating the species.
Yes, we're preparing for possible fertilization and implantation of the fertilized egg in the uterus. Well, it's not just the uterus that prepares for a possible impregnation. Once a month, a woman also, breasts are getting prepared for possible breastfeeding. Once a month. So once a month, you create extra breast glandular cells, and your breasts get fuller. And the way you create extra breast glandular cells is by cell division. Mitosis, it's called. Well, that's a great phenomena. You create extra cells by cell division. But in the world of special health care, we're not real fans of cells dividing in a menopausal woman. And one of the reasons is that's a vulnerable moment as the genes are exposed. And that's a moment where there can be genetic mutations. So, young women with robust immune systems, fine. But in menopausal women, we don't want to put a woman through mitosis.
Right.
When she's in her 50s and 60s and 70s.
Right.
So that's the reason why, and I discuss this in the book.
I also did put up the screenshots of dose determination and so on. I always say pages 326 and 327. I have the insert, and I did post that on the Ins and Outs of Menopause group for all women to see.
And yes, the menopause method does treat thyroid. In fact, when we train physicians, the longest segment is on thyroid. We want our physicians and nurse practitioners and prescribing compounding pharmacists and PAs who take our program, we want them to become expert in thyroid. Why? Because so many midlife human beings have overtaxed our thyroids. I take thyroid hormone. Overtaxed them. We don't have thyroid disease, but we sort of tired them out. They're not putting out youthful levels of thyroid hormone, and that really, really matters as well. So part of our training program is they become experts in thyroid. So you betcha we do treat.
Very, very, very nice. It's all, as you've taught me, interconnected. Here is a question that I would like to ask you. Questioner says, I am not treated with hormones, and I am feeling hot and cold at the same time, which is very weird. I have many symptoms of anxiety off the charts, also skin issues from food intolerance, and sometimes body tremors. I've heard you say, excuse me, so much that it is good to treat the menopause and then what is left over, meaning treat the menopause first and then treat what is left over. You don't know me, but I'm wondering if hormones might help to take these awful symptoms away.
Yes.
Yes.
Next question.
You got it. There are 13.
No, I can't stand it. I can't.
No, you can't.
You know me well enough at this point that I can't stand a one-word answer. It just gives me nausea.
Just say maybe. Open-ended.
I mean, every single woman, symptomatic or not, and every single man on the planet Earth should do this new biological, geological phenomena that we're facing. Like for 200,000 years, human beings have been evolving and on this planet. And for the vast majority of those 200,000 years, there was no such thing as menopause or andropause. No one lived that long.
Right, to know.
And then through hygiene and nutrition and other factors, oh my God, women started living beyond the reproductive period. And it's called menopause. So menopause was born, but there was no genetic adaptation to this. A new human being that kept on producing these crucial ovarian hormones, not necessarily at a level to be fertile and menstruate. That little glitch did not get repaired.
Right.
It is interesting because I talked to so many women in menopause. I just heard of a woman whose mother and grandmother went into menopause at 60.
Wow.
So, but this is very, very rare, extremely rare. This is the first case in 25 years of specializing in menopause that I heard this. So there's been no genetic adaptation of the human being, male or female. And we didn't even know men were getting low on hormones until Viagra came out.
Yeah.
And it became overnight one of the most extraordinarily popular drugs that is produced. And why were men so attracted to Viagra? Because they were not getting an erection anymore, or they had a much different, softer, not as full erection as they ever had in their whole lives. Why was that happening? Because their testosterone levels were dropping. And it isn't just the erection that gets affected in men. Men, like women, lose their muscles, lose their drive, testosterone, lose their mood. Testosterone is so crucial for women and men. Testosterone is not a male hormone. It's a human hormone. And women, you need testosterone as much as you need air. Well, not that much, but because you want to preserve your muscles and you want to preserve your bladder, and you may even want your libido, and you may want to not have to go to a cane and walker and wheelchair and assisted living facility. Without testosterone, you pretty much go there. Oh my God, have I wandered away from what that question was?
And you know what? It's okay because it all really comes together. It does. She's feeling hot and cold at the same time. She's got symptoms of anxiety, body tremors, wants to take hormones, doesn't know if she can take hormones. She's confused.
Yeah. Well, there's some classic symptoms of insufficient hormones there. Two of the three major things you're mentioning. The, for a woman to have warm and cold phenomena, go interview 8 million 25-year-olds and ask them if any of them are having any warm and cold phenomena.
They're going to look at you like, huh?
Well,
right.
They're not having, maybe 1 out of 8 million is, but they're not getting warm and cold phenomena. And there's reason why you're getting that is the body is so stressed by low estrogen levels that it triggers the biology of the stress response. So you pump out some nice adrenaline and cortisol, and that's what is behind that dilation and constriction of your blood vessels, warm and cold. And I'm not going to go further into detail, but that's how you get warm and cold. You get stress hormones. Oh, that's nice. Let's put out some extra adrenaline and cortisol. You don't want to do that if you don't want to gain weight, because that's a perfect storm for insulin resistance and gaining weight, just for openers. But those vasomotor phenomena, they're called, are really because of low hormones. And they're just like this wonderful, amazing clue delivered by your body saying, I don't feel good. Would you please get me some help? Or would you please figure out what I should do about these warm, cold phenomena? And the other one is the mood stuff. I can't tell you how many women in menopause have major mood issues. And these are strong women who, yes, we all have the emotional vicissitudes of life and personal growth. Absolutely, we do. But I have talked to so many women, they never used to get depressed. They didn't know the word depression. They knew uncomfortable mood. They didn't know the word anxiety. They knew feeling stressed, but they didn't know the word anxiety. If that hasn't been a common theme in your earlier life, and all of a sudden you're getting anxiety and depression and really off-kilter mood, I mean, I've seen severities in this. The high likelihood is you're dealing with low hormones. I mean, progesterone. If I injected progesterone into my veins or Carolyn's veins or anyone's veins on the planet Earth, male or female, and I gave us the right dose, we would calm down. Oh my God, would we calm down? We could calm down so much, we could be put to sleep so deep, surgery could be performed on us. Progesterone is a very unusual hormone. Most hormones are activating for fight or flight. Progesterone, and the only other exception is melatonin. It's calming. Some women in pregnancy, they get so calm, it's like they've taken on a calm religion or something because the progesterone levels are so high. So women who develop anxiety in their 30s or 40s or 50s out of the blue, they're leading good lives and they're getting anxiety. Man, they're losing their progesterone, and you want to get on the progesterone bandwagon because it's so good for you. And then mood disorders like depression. I mean, you take a man's testosterone away. What's going to happen to his mood? It's going down. And you take a woman's estrogen and testosterone away, or her progesterone away, you get into major mood disorders. These chemicals, these biochemicals, are some of the strongest biochemicals that are circulating in our body, and they relate to the brain big time and the mood big time. So, longer answer than needed. Get thee to a menopause specialist and get treated, and for your whole life. You're not even, what you'll learn over time is how wonderful that my mood broke down and I had these crazy heat cold phenomena, because it drove me to find a solution to this. And then over time, you're going to learn. I think we're frozen.
No,
Okay.
I'm just stupefied.
Over time, you're going to learn that it was a miracle you had cold phenomena and you had these mood disorders, because it drove you, it inspired you, it motivated you to go get some help. And then what you don't know is when you get that help, you're not only going to be addressing your mood. Are we still connected?
We are.
Okay. You're not only going to be addressing your mood, you're going to be addressing with great success your bones, your arteries, your brain, your memory, your thinking ability, your vagina, your bladder.
Not going on to the
ability to walk and not have to go
right.
to canes and walkers and wheelchairs because you've lost your lower extremity muscles.
And assisted living.
Yeah, because when you, like Carolyn just said, like when you lose the ability to walk, so many women can't stay in their family home, which is what they want. And they are strong and they are willing to make those transitions to assisted living, but it's devastating.
It is. And I see it. I see it often. I keep my mouth shut because it's a conflict of interest, but do I have to keep my mouth shut.
So you want to prevent this. So you can get down on your knees right now if you're listening to this Facebook Live and thank the Creator that you are getting disturbing symptoms galore, and it's inspiring you to get out there and get a resolution to those warm, cold things.
You've often said that it's the women who are symptomatic you're okay with because they do seek help because we're so uncomfortable. It's the women who do not present with any symptoms that concern you the most.
Absolutely.
Yeah, and I think that's really important.
Because 25% of the women, they go into menopause and it's pretty seamless for them. Mm-hmm. And they look around, they go, what's everyone complaining about menopause? And they don't do the hormones, but they have the same deep problems. Their vagina will atrophy. They're most likely to lose bone. They're certain to lose muscle, almost certain to lose muscle. And it's the same progression. They get into the same long-term deep difficulties. It's the deep difficulties. You know, we tend to think of treating menopause for the symptoms of menopause. That's not how I see it. I see the most important thing about treating with these hormones is the preservation of the mind, the mood, the arteries, the bones, the vagina, the bladder, the muscles, to name a few. That's because the long-term effects of those losses can have you be leaving your family home and moving into an extended care facility. And God bless the people who work in that industry. Thank God they're around, and there's some beautiful people who do that work. But I can tell you from my interviewing women, including my own mother and mother-in-law, my mother so much would have liked to stay at home. But she got unmanageable. She needed the care of an assisted living facility. And that was a monumental change. I can picture her the day we walked into the assisted living facility. Oh my God. And she turned to me and she said, because she didn't know what was happening. She had enough cognitive decline that she didn't quite grok what was going on. And as we're walking in the door, she said to me, "Is this an old folks home?"
Oh my God.
And oh my goodness, it was so uncomfortable.
Yeah, it's devastating.
So I'm saying that personal story because you don't want that to be you, and you don't want that to be a relative of yours.
My quote of yours is that our lives are going to matter as much to us then as they do to us today, whether we're 45, 55, 65, 75, 85, 95, right?
Well said, Carolyn. Yeah.
Well,
my mother's life mattered as much to her.
You bet.
She was in her late 80s. My mother-in-law's life mattered as much to her. But she was at the mercy of stuff that she'd never done because she never wanted her son to be talking to her about hormones, her being your doctor, because she was old school, and that
Yeah.
didn't fly.
Yeah. Oh my,
Yeah.
my uncle at 96 was in an assisted living, and he was not happy.
Yeah.
And he just kept saying, "I can't wait to get out of here."
Yeah.
So thank you so much. That answer always touches me so deeply. It does. Um, may we? Yeah, we're a little ahead of time, so this is good. May we please touch again on the subject of doing an estrogen detox clearance, the why it is important for us to do. The third question with this, can we do it while we're taking hormones, or should we do it prior to taking hormones? This estrogen clearance detox thing.
Yeah, estrogen clearance detox. Let me talk about that a little bit because it's an interesting subject.
Yeah, it's a little confusing.
Yeah, and there's experts in this field, and of course, one of our dear colleagues, and brilliant physician, Dr. Lindsay Berkson, books on this. And what is it? What do you mean estrogen detox? Well, when you hear the word detox, you wonder, oh, I guess that's addressing toxicity. And yeah, toxicity on our planet is a crucial issue, and we don't, because we get toxic exposure molecule by molecule. It's not like we say, oh, look at this. Here's a glass of arsenic. I think I'll just drink it, and we keel over and it's all over.
I have mine right here.
You drink arsenic?
No.
Or hemlock?
Yeah, hemlock.
It doesn't work like that. The toxicity is sort of low grade, but still poisonous. So we get exposures every day, and this modern world is just really unusual. All of these chemicals that are in our lives, the gasoline, the dinosaur products, really, all these things that derive from oil and petrochemicals, what do you know? They turn out to be poisonous. Now, they're not like a glass of arsenic, but they are molecule by molecule, and they're fat soluble, so they accumulate in the fat tissues of the body. So we can build up enough of these chemicals if our exposure is, day after day, and our exposure is day after day. The food supply, if it's not organic, is loaded with herbicides and pesticides. Well, let's see. How strong a chemical does it take to kill an insect, these hardy creatures, or to kill an herb? How strong a chemical do you need? Strong.
They've been around for zillions of years.
And workers that go out and spray this stuff in our fields are subject to illness because the amount of poison they get exposed to is very high. And, between the dry cleaning fluids and the stuff you throw in your dryer that's got some kind of odor and the air fresheners, these are all chemicals. And look under your kitchen sink. All your cleaning supplies are loaded with chemicals unless you've been diligent to get non-chemical stuff. It's everywhere. You walk into a mall, you're inhaling all kinds of chemicals. Well, what is the clinical significance of this? Well, wouldn't you know, or wouldn't you never suspect, that some of these chemicals bind with hormone receptor sites? Like Gavalt, what do you mean?
Gavalt is right.
Like, there was a study done on Florida alligators because they were really curious of why weren't they reproducing at the rate. Well, their sperm counts had dropped dramatically. Well, why was that? They held it was because of the toxic chemicals in the Florida water, which is, Florida's got a lot of toxic stuff in there.
So do we in LA.
And what happened in my lifetime, when I was in medical school, the sperm count for an adult male was reported in a reference range that's 5 times its current reference range. What they did over time is they just reduced the reference range of male sperm because men are getting affected because some of these chemicals some of them are known as xenoestrogens. That means they mimic estrogen. Oh God, that means they're interacting with the estrogen receptor sites. So is it a good idea to do some kind of procedure to eliminate these chemicals that accumulate in our fat tissue? You don't just pee them out when you get these. Like if you take too much B vitamins, no sweat. They're not going to accumulate in your body. You're just going to pee them out. But that's not so with fat soluble anything. Can you still hear me, Carolyn? Because
I can.
Okay,
Yeah.
good.
Yeah.
So when you go to a health-oriented coach or supporter or a functional medicine-oriented healthcare professional, they're going to evaluate your toxic exposure. And for long-term health recovery and health optimizing, you're going to go on a detox program because we know that you've accumulated toxins if you've been walking on this planet all over the place. Now, how crucial is it for a woman in menopause? Well, I would never delay the hormonal treatment of a woman in menopause to do a detox.
Right.
And would I recommend to man and woman at midlife to get interested in toxicity and detoxification? Absolutely, I would. The very first thing we recommend is a scrupulous clean out of all the toxins in your house. Look out, folks. The nice thing is everything gets cheaper and easier because with baking soda and distilled vinegar, you got all the cleaning products that you need, plus an environmentally clean laundry soap and dish soap. How simple is that? You don't have to buy all these crazy products that people use that are toxic. They're strong and they're toxic.
Carpet.
Oi.
Fans. I could go on and on.
Yeah. All over the place.
Yeah.
And some people have accumulated so many toxins and are so sensitive to them that they get a syndrome called environmental illness.
Yes.
And man, these are the experts among us in detoxifying because they have. And they'll take carpets out. They'll have to deal with mold. They'll deal with a ton of stuff. But the moral of the story is, if you're going into menopause, just take on priority number one, get these hormones replenished. And most of you are going to do super well. And there's going to be a few of you who are not going to do well. And you might have receptor site issues. You might have toxic accumulation in your receptor sites. Well, we discover that as we go. And and Dr. Berkson has written books on this. Some of you will have too much of toxic exposure, not going to respond well to the hormones. And yes, you should do a detox procedure early on. I would never slow down the implementation of a hormone replenishment program, although I should never say never, because sometimes a woman is just got such a toxic overload that detox is the very first thing she needs to do to prepare her body to be able to receive hormones.
Right. Every woman being so individual.
Precisely, Carolyn.
Yeah. Oh, Dr. Rosensweet, thank you so much. Do you know?
What?
We got through all of our questions.
Wow.
Not one move either.
Yes, right.
Oh, my. So, I thank you so much for these great answers. These interviews are always so fabulous to do. And I know for me they are, but boy, I hear about it. And the questioners I will get with you. I will attend to your questions absolutely for Tuesday and Thursday's interviews. And we are right on the button. It's 8:00 a.m. How about that?
That's great.
I know. So I want to wish you
good to see you, Carolyn. I wish you and Daryl a really lovely weekend.
Thank you so much. We are busy.
All of our Facebook people out there.
Indeed. Our village. Our amazing village.
Have a Carolyn, I'm going to sign off.
Have a really fabulous, wonderful weekend to you, my dear Dr. Rosensweet, to all of our wonderful, wonderful guests, and to all of us here, sitting here, 3 of us, the 2 cats and me. We will sign off, and we will see you on Tuesday, and thank you so much.
Thank you, Carolyn.
Thank you, Dr. R.
Bye-bye.